and I am happy to introduce Professor Keith Fox from Edinburgh, who have actually been behind the program of the annual ESC congresses. And he has come here and will talk about vascular protection. The future is already here. A contemporary new antithrombotic treatment of vascular disease. Keith, this is a challenge, isn't it?
Lars, thank you very much. Yes, you've set us a challenge. And underlying your question is, where are we and where are we going? And that actually is not a quote from Theresa May. It's about chronic vascular disease. But it's a serious issue. It is a serious issue. We've heard just in the first presentation from Professor Jernberg about the ongoing risk and the contribution of risk factors. So I'm going to try and address this question. These are my disclosures, and relevant to today, I was co-chair of the COMPASS program. So let me begin with a clinical case, and I want everybody to vote. So this is a 70-year-old woman with a prior MI, and she has prior hypertension, type 2 diabetes, which she's had for 10 years. She had a non-ST elevation MI about 4 years before, but found to have diffuse three-vessel disease without the need of a stent, no significant stenosis. BMI is up a little bit, non-smoker, well-treated hypertension, LDL 1.8, HbA1c of 5.5. And you can see she's on a calcium antagonist, a thiazide, a diuretic, oral hypoglycemics, SGLT2 inhibitor, statin, and aspirin. So reasonable. She was tried on an ACE, but actually she didn't like the ACE, so she's got good control with her thiazide and calcium antagonist. So my first question to you is either yes or no. She should have further treatment for secondary prevention, either yes or no. How many people say yes? Okay, how many people say no? How many people say don't know? People with 2 hands up. Okay, so what are the options? The options are more aggressive LDL lowering, which would be an option for her. Should we modify inflammation? This is not approved in any of our countries, as with, for example, canakinumab. Should she have additional antithrombotic therapy, either with dual platelets like ticagrelor plus aspirin, or rivaroxaban plus aspirin? That's the dual pathway. So these are the underlying questions. Let's look at our guidelines. Our guidelines say control the risk factors to prevent atherosclerosis progression. So she's doing quite well on the guidelines. She's a non-smoker, she does exercise regularly, she's a little bit overweight, but otherwise pretty well on lifestyle. Her LDL is not ideal, and I would argue that she needs further LDL reduction. You could argue that she'd be better off on an ACE inhibitor. I said she didn't like that very much, and she's got good blood pressure control, and she's on good diabetes control and SGLT2 inhibitors. At the moment, our European guidelines say single antiplatelet for chronic vascular disease, unless they can't tolerate aspirin, in which case clopidogrel. Let's look at the question of dual antiplatelet versus aspirin. So we know from the old Capri study, remember that that study was done before good blood pressure control, before lipid control, and that there was a relative 8.7% relative risk reduction in the combined endpoint, a half of 1% absolute reduction in a combined endpoint. If we look at the Charisma trial, the trial as a whole, including those at vascular risk, was neutral. In those that had documented coronary disease, vascular disease, there was about a 17% risk reduction. We know that ticagrelor aspirin is superior to aspirin alone post-MI. And we know that vorapaxar combined with clopidogrel and aspirin is superior to clopidogrel and aspirin. But all of these are associated with some bleeding risk and no reduction in total or cardiovascular mortality for the long-term treatment. Let's just review what's behind our European guidelines for secondary prevention. And for the moment, I'm showing you 1 millimole of LDL reduction or 10 millimeters of blood pressure reduction, ACE inhibitors, aspirin. Just concentrate on the blood pressure. So 10 millimeters, this is the reduction in combined cardiovascular death, MI, stroke, mortality, stroke, and MI. Pretty impressive results. And the additional options for the kind of lady that I'm presenting to you is either switching her to a high-intensity statin like rosuvastatin, adding in ezetimibe, or adding in a PCSK9 inhibitor. I've said the inflammation modification is perhaps in the future not approved at the moment, and the antiplatelet options we just discussed. So for our patient, according to the previous ESC 2013 guidelines, low-dose aspirin unless they can't tolerate it, patient with coronary disease. And for PAD, it's an antiplatelet therapy. Let's go back for a moment to the old trials of warfarin, VKA, for secondary prevention. No change in death, reduction in MI, reduction in ischemic stroke, but offset by bleeding, both major and minor bleeding, and hence warfarin was never adopted for long-term vascular disease patients. So what about the future and modification of inflammation? I'm showing you in the middle of this figure the so-called inflammasome. This is the change from a pro-IL-1 beta to an active IL-1 beta, and then the cascade of interleukin activity that can be antagonized. And it worked. It worked over the course of 5 years. You can see the placebo arm, and you can see the canakinumab arm, and there is about a 15% relative risk reduction. But rather modest, and you could say not all that impressive in absolute terms, about 0.4 of 1% in the primary composite. And even in the higher risk groups with greater high HS-CRP reduction, there was no reduction in death, no reduction in cardiovascular death, no reduction in stroke. Now, they're very impressive results from profound LDL lowering. And these are just one of the trials from Odyssey Outcomes, 19,000 patients treated for at least 3 years. And you can see that there's about a 40% reduction, further reduction in LDL that is sustained. And there is a reduction in the primary endpoint over the course of 4 years. You can see the difference in the combined endpoint, which includes unstable angina. Cardiovascular death, not different, a minor trend for all death. So why COMPASS? In COMPASS, we took advantage of the interaction between activated platelets and the coagulation system. So the most potent stimulus for platelets is thrombin and vice versa. And we tested 2 different concepts. One was combining 1/4 of the full AF dose of rivaroxaban with aspirin given as 2.5 BD, or the half dose. And I can tell you that when we unblinded the steering committee, we all became unblinded. Nobody got the answers entirely right. So there were uncertainty as to what we would find. And it was sufficiently powered, and the trial was designed to be conservative. The DSMB could only stop the trial early if there were 4 standard deviations of benefit. And much to our surprise, the DSMB recommended early stopping of the trial. Why? Because at just less than an average of 2 years, there was a 24% reduction in cardiovascular death, MI, and stroke. You can see the upper line in red is aspirin. In blue is rivaroxaban 5 milligrams BD alone without any antiplatelet. And this is the 2.5 BD with aspirin, which was the only arm to be significant. Here is the absolute differences. And for the rivaroxaban plus aspirin, 4.1% versus 5.4%, an absolute difference of 1.3%. Whether you got into this because of coronary artery disease or PAD, the hazard ratios were very similar. And if you were a younger patient, we've just been hearing about the risk factors. If you were less than 65, you needed augmentation of having disease in 2 vascular territories, or chronic stable heart failure, or renal dysfunction, or diabetes. So you had to have augmented risk factors to get in. There is an offset in bleeding. And you can see that the hazard ratio for major bleeding is 1.7. So there is excess bleeding. But remember, this is the modified ISTH bleeding. And this modified ISTH bleeding has about 30% more bleeds than the original ISTH. So if you attended hospital for a bleed and you did not need transfusion or invasive treatments or surgery and were sent home the same day, you were still counted as a bleed. There were minor trends in fatal, non-fatal ICH and other non-fatal organ bleeds, but these were not significant. Whereas you can see that there were also hazards for the rivaroxaban alone. Now, what's very interesting, and this will be published very soon, is the information about bleeding over time versus effectiveness over time. So the bleeding increases in the first year, modestly, but it does increase, and then is sustained over time, whereas the benefits diverge and continue to diverge over time. Net clinical benefit is highly relevant in all our healthcare systems. So this is the combination of the primary endpoint and severe bleeding, and there is a 20% reduction in net clinical benefit, a 25% reduction in cardiovascular mortality, and a 23% reduction in all-cause mortality, which obviously will incorporate any impact of bleeding. So this combined treatment is associated with improved outcomes, principally driven by a reduction in stroke. This is very interesting. There were strong trends for MI, but not independently significant. When you combined MI with sudden deaths and resuscitated, it was interesting and showed a strong signal for benefit, and the combined reduction in all-cause mortality. So what if we just list these results from COMPASS? And as I've said, we must be cautious anytime we show trials side by side, because the populations are not the same. But at least we can see that in COMPASS, the reduction in death, MI, stroke, the reduction in CV death, in stroke, here's the MI, there's the bleeds, and there is ICH. This is at least interesting, looked alongside the other trials. And interestingly, maybe we have forgotten the impact of bleeding in dual antiplatelet therapy, but we should not forget it. And let's look at this alongside our standard of care for secondary prevention, like 10 millimeters of blood pressure lowering. What we can see is that there are at least comparable impacts on cardiovascular death, death alone, stroke, MI. And at the bottom, This is not the hazard of being male, although that is a hazard. This is a major adverse limb event, which is too often cardiologists are focused on the coronary tree and not enough on the rest of the vasculature. We've got to address that. So how do we bring this to a close? What I proposed in the recent publication in the European Heart Journal was that the enhanced secondary prevention, the first step is after MI or ACS, clearly there is an indication for dual antiplatelet therapy. After stenting for stable arterial disease, an indication for DAPT dual antiplatelet therapy, determined by the clinician as to duration. For chronic vascular disease, no routine DAPT is indicated. The first stage is intensifying the guideline-indicated secondary prevention and lifestyle. So that is clear. The next stage is if there's elevated vascular risk despite guideline therapy, then the potential options include profound lipid lowering, the new COMPASS regime, and maybe in the future modifying inflammation, but we're not there yet. So finally, we've heard about the ongoing risks in the first year and afterwards. And these are the options for treatment. What we have to discuss is the magnitude of the gain, the absolute difference in terms of net clinical benefit, selecting cohorts with the most to gain, and the cost effectiveness. But at least we have new options for management of our patients with chronic vascular disease. Thank you very much.